It has started. Okay.
Okay, am I audible now?
Yes.
Yes.
Now see, if these are the homologous chromosomes, then on the southern blotting, the bands will appear different, right? Okay, like that, as you can see in my circle, these are the homologous chromosomes. This is a one copy from the male father, and these two copies of homologous chromosome are came from the mother. And because these are homologous chromosomes, they're appearing as three bands, three different bands. And if it is a sister chromatid, like in this case, the bands will appear only two. One band from the male father of 21 and two bands here, which become one because these are sister chromatids coming from the female parent, right? You guys appreciate the fact?
So you mean to say
Yes.
that in example number 1, it was non-disjunction in meiosis 1, and the right now example is of non-disjunction in meiosis 2?
Yeah, exactly. Because in meiosis 2, if the non-disjunction occur, what you will get the sister chromatids in the
Of the same
fetus.
chromosome.
Yes. Yeah, exactly.
Same copy, exact copy, and that's why the
Exact
band will appear
copy.
very thick. But only two
Very
bands will appear because these are sister chromatids, right? So they will found at the same
Okay.
location in the southern blotting. But in
Okay.
case of the homologous chromosome, what you will get are three bands of different sizes, right?
Yes, because the blue with blue sister chromatids shown in this just example are from two different other chromosomes that are homologous to each other, right?
Yeah, exactly. So now you understand this concept here. They will ask you by giving a southern blotting. If they give you a three bands, that means they're showing a homologous chromosome. If they show you only two bands, that means the sister chromatids. Okay. So this is
Okay.
about the non-disjunction, the meiotic non-disjunction, and you should know with the increased maternal age, you will get an increased chances of getting this trisomy. Okay. So, and the highest chance is in the woman who is becoming pregnant after the age of 45. Okay. And along with 95% cases, 4% of cases can be occur due to the Robertsonian translocation. I will explain that to you in the next page. But 4% of cases can be arise due to the Robert translocation unbalanced. Okay. And only 1% of cases can be happened due to the mosaicism. Remember I told you. And as you can see, the FA writes the 1% of cases are due to the post-fertilization. These cases are not inheritable. They happen very
Okay.
sporadically.
Yeah.
Post-fertilization, okay? So these are non-inheritable, mosaicism. And you need to know what tests you will do for the Down syndrome. What are the tests? First of all, you can do the ultrasound, okay? And when you do the ultrasound, you will get a nuclear translucency because you know their nose become very flat, right? And their nose will lost their, normal shape. So you will get a very abnormal nose, also known as a nuchal translucency. You will see. Sorry, it is a neck, not the nose. It is neck. I forgot to mention about some symptoms of this Down syndrome, which is you will get a short neck and very excessive skin over the neck. And you will also get the cystic hygroma, which is a disorder of your lymph nodes in the neck. You will get a very enlarged neck. Okay. You will has a photo of the cystic hygroma. You will see that in the later when you encounter a question over it. The short neck with excessive skin and cystic hygroma is also a very characteristic feature of the Down syndrome. And protruding tongue you will get, and very furrowed, you will have very these indentations on the furrows on the tongue. And there is also upslanting palpebral fissures, which is the shape of your eyes actually. Normally we have this horizontal flat eyes, right? But in these patients, they have this inclined upslanting eyes like that. Let me show you. They will have eyes like in this direction, like that. A normal person have eye like that. Okay. So these are difference between the eyes of these patient and this patient. This normal patient, these are Down syndrome. They will have this upslanting palpebral fissures. Okay. And apicanthal folds are like, this is your nose. Sorry, made it wrong. This is your nose, and just here is your eyes, right? And you will get this prominent fold here. This fold is very prominent. It will cover up some of your eyes even. This is a prominent apicanthal fold you will get in these patients. I hope you understand. You will have a very nice diagram of these Down syndrome patients, so you can refer it to there.
Yeah.
Okay, now, so we're talking about the ultrasound, and in the ultrasound, you will get a nuchal translucency. Second is the hypoplastic nasal bone, because your nose will be lost. You have very abnormal shape of the nose in these patients. The usual shape of the nose will be lost, and you will get a hypoplastic nasal bone. And some of the markers for the Down syndrome that you should know for the first trimester screening and the second trimester screening, that is the beta HCG and the PAPA, PAPPA. So the beta HCG is increased in the Down syndrome in the trisomy of 21, and the PAPA will be decreased in the Down syndrome. That is the first trimester screening you will do for the Down syndrome. In the second trimester screening, you will use the beta HCG, the inhibin, the estriol, and the alpha fetoprotein. The beta HCG has already increased, and so that the inhibin A, the estriol would be decreased, and as the estriol decreased, your inhibin A will be increased. These are linked. Estriol decreased, so inhibin A will be increased, and the alpha fetoprotein is also decreased in the Down syndrome. You should know this fact, very important. They will ask you what are the first trimester markers that you will use, or what these markers will show in the Down syndrome. So you should know the fact here, okay? And just it, no other thing. One more thing that you will get is the atlantoaxial joint instability in these patients. Atlantoaxial joint is basically a first and second cervical vertebra joint. It will become very unstable, okay? You can also get very neck pain because of it, and some abnormal gait and torticollis can also happen in this patient, which is an abnormal contraction of a group of muscles. Okay, so this is about the Down syndrome. Any doubt, guys?
No.
Okay, so we will move forward with the Edwards syndrome, which is a trisomy of number 18, chromosome number 18. So what you will get is a prominent occiput. I have shown a diagram here. This is a prominent occiput. Okay, you will get a low set of ears. You will get a micrognathia. So in the face of Down syndrome, you will get a face, very flat face and a furrowed tongue, and a loss of nose, some part, and up slanting palpebral fissures, right? A prominent apicanthal fold. What you will get on the face of this Edwards syndrome patient, that is a micrognathia and low set of ears and a prominent occiput. Okay, their fingers, their fist is always clenched, their palm is always clenched, so you will get a clenched fists in these patients with the overlapping of these fingers. As you can see, their fist is very abnormal. They will always make a fist on our hand, in their hand, and they have this overlapping fingers. Okay, they will have this micrognathia. They will have this raucous bottom feet. As you can see, this abnormal shape of the feet, this is a raucous bottom feet. Okay, and they will also have this heart disease, just like Down syndrome. VSD, PDA could be there. Omphalocele is seen in these patients, which you will see in the GI tract. I will tell you about this omphalocele in the GI system, and you will get this myelomeningeal, which I will tell you in the neurology section about it. It is a disorder of the spinal cord, actually, right? And this disease is so much severe that the death of the patient will be occur by the age of 1 year. Okay, so you should know the symptoms. You should know how to recognize this disease. They will ask you about this trisomy thing. You should know it. They will ask you about this omphalocele. Most importantly, you should know it. And this myelomeningocele, you should know it. Okay. Then the Petou syndrome, which is a trisomy of number 13. What you will get on the face of this patient? The microphthalmia, which is a very small eye. Okay, you will get an opening in the head of these patients, which is cutis aplasia. The skin over the head will be lost. Okay, this is a cutis aplasia you will get. Okay, you will also get a holoprosencephaly, which is a joint, like in the normal brain, you have two cerebral hemispheres, right? But in these a patient's the hemisphere will be lost. You will have a complete one single brain. Okay. This is the holoprosencephaly. You will get the cleft lip and palate, the polydactyly, which is multiple number of fingers, more than 5. And just like your Adva syndrome or the Down syndrome, you will get the congenital heart disease. You will get the polycystic kidney disease, the omphalocele, just like the Edward syndrome. And death is usually occurred by the age of 1 year. Okay. And for the markers of the screening, you should know that all the markers would be down, as you can see, low. So you don't need to learn this very specifically, just learn the markers of that Down syndrome, which marker will be high, which marker will be low. And in other cases, all the markers would be low. Okay. Any doubt?
No.
Just learn the symptoms by the category. What symptoms will be present on
Yeah.
face? What about the hands? What about the other organs? Yeah, someone is saying something.
There is a defect in precaudral fusion.
What?
There is it's written there is a defect in fusion of precaudral mesoderm. Can you explain that?
Mesoderm. Yeah, defect in fusion of the
There is a
precaudal
defect in
mesoderm.
precaudal mesoderm.
Precaudal
Yeah.
mesoderm is basically a specific, it is a special lining which, this is a mesoderm actually, which is a middle layer, of course, right? And precaudal is basically central hoti hai na? This line is very central. This layer is very central. So you will always get a midline defects because of this. It is a special mesoderm which is found in the, in the midline of our body. Okay. It is not that much important. I've learned about it, but now I forgot actually. You can
No
Google it
problem.
actually, and
Okay.
Shouldn't it be like the single nostril and single central orbital fossa? Like, because
yeah, all the central defects that are occurring in the Pitta syndrome are due to this precaudal mesoderm because it is found centrally, right?
yeah.
Yes, exactly. Yeah.
So there's going to be one eye and one orbit, something like that.
Yeah, that holoprosencephaly you were talking about.
Yeah, exactly.
The cyclopsis.
Holoprosencephaly. Yeah.
Cyclopsis,
Failure to
right?
separate right and left.
Yeah, exactly. It is due to it is due to this fact. Okay. Okay, so should we move forward now?
Yes.
Okay, then the which chromosome has which abnormality, you need to know, guys. You need to learn this table. There is no easy way. Just write it down again and again and again. Eventually you will learn it. Okay, so I'm skipping it. Let's move to the Robertsonian translocation now. Robertsonian translocation occurs in the acrocentric chromosomes, which are the chromosome number 13, 14, 15, 21, and 22. The easy way to learn it's like 1, 2, 3, 4, 5, 21, 22, 13, 14, and 15. These are the acrocentric chromosomes. What are the acrocentric chromosomes? They're having this kind of shape. Let me show you. The one arm is very big, like that, and one arm is very small, like that. These are the acrocentric chromosomes, as you can see. Okay, and this happens in the 21, 22, 23, 21, 22, 13, 14, and the 15. And I already mentioned you guys in the Down syndrome that one of the cause of the Down syndrome is an abnormal Robertsonian translocation, which happened between the chromosome number 14 here and chromosome number 21 here, as you can see, because 21 is an acrocentric chromosome. Okay, what happens is actually there is one, let us suppose this is 14 number chromosome. This is your 21 chromosome. What happens abnormally, these smaller ends would be lost and these larger ends would join each other. So it would become like this, right? This is number 21 and this is number 14. And then it will get transferred to one generation to another, right? And this is a familial case of the Down syndrome. You will see multiple males or females would be affected by this. So this is a Robertsonian translocation. Okay, and how the question system can ask your question on the Robertsonian translocation. So you should know the fact that whenever the question system explains you a scenario where the female is losing multiple fetus, when the when the patient is having multiple miscarriages, you will always think first about this Robertsonian translocation, which is the most common or very important cause of the miscarriages. And even though if the child is live, it will be a stillbirth. He will live with very chromosomal abnormalities like multiple hands, or might be multiple fingers, or abnormal faces of the body of the face of the patient. So whenever the question is describe you a case where the patient is having multiple miscarriages, and the boy who lives or the female who lives will be having multiple abnormalities in the body, that must be a case of your Robertsonian translocation. You can write this note here. It's one of the NDMEs I've taken.
The example you have given is of unbalanced translocation, right?
Yes, it is unbalanced because this area is lost, right? And these areas are joined together.
And can you
So it
please
is
show how
unbalanced.
does the balanced translocation of Robertsonian occurs?
Balance will occur when there is equal amount of this area and equal amount of this area. This is balanced. And when the
Okay.
balanced translocation occur, there won't be any symptom, right? If the balanced translocation occur, there won't be any symptom because every patient will have every single chromosome in the exact amount, right? This is balanced. But unbalance will occur when it has extra copy or loss and copy of the chromosome. Then the unbalance will occur. You understand what I'm trying to say? If there is 2 copy of 21 and 2 copy of
Yeah.
14, then it is balanced. Okay,
Okay.
in the karyotyping. But if there is extra copy of 21 or extra copy of 14 or loss of 21 or 14, then this is an unbalanced translocation that's causing the symptoms.
So the example you just gave of acrocentric chromosomes, the short arm of the
Yeah.
chromosomes is lost. Both arms are lost.
Yeah.
Short
Actually,
arms.
actually, this lost arm has very few genes in them. So it doesn't really matter if they're present or not. There are very few chromosomes. It does not affect much in the body.
So if they are not very important, then why are the symptoms occurring? Just because of the extra copy of that chromosome?
Yeah, exactly. Symptoms are occurring because
Not
of
the
this
loss.
extra copy of, yeah.
Rather than the loss of these small number of genes.
Yeah, exactly. No. Not of these genes, but due to this extra copy of chromosome present. You understand what I'm trying to say?
Yeah.
Okay, so should I move forward now with the Cry-Duchet
Yes.
syndrome?
Yeah.
Okay, so now the Cry-Duchet syndrome, which is occur on the chromosome number 5, and you should know that it is a deletion on the short arm of the chromosome number 5. The short arm is represented as 5p. P is the short arm and Q is the long arm. So deletion of the short arm of the chromosome is on the chromosome number 5 will lead to the Cry-Duchet syndrome. And you should know that gene is present on this chromosome number 5, which is responsible for your voice regulation. Okay, and because these patients will lose their voice, they will have very high pitch crying. They will cry like cats. Have you ever seen a cat crying? Ever heard?
Yeah.
They will cry like that.
Okay.
And they will have very severe intellectual disability. They will have this microcephaly, which is a small brain, and they will have again the cardiac abnormalities, which is VST. So as you can see, every disease we are encountering here from here to here, all of them are having the cardiac abnormalities, right? And even the Belgium syndrome will have the cardiac abnormalities. So you should, remember this thing. It will have you memorizing it very easily. That every of the disorder will have a cardiac abnormality. Okay. So any doubt in Cry-Duchet syndrome? I think it's easy. Nothing to understand, but just learn it. Yeah.
Yeah.
Okay. Someone was asking something, I guess. No? Okay. So now the Williams syndrome, which is occurring due to the micro deletion of the long arm on chromosome number 7. This is a deletion on the short arm of 5. This is a micro deletion of the long arm of the chromosome number 7. Can anyone tell me what technique I use for the detection of micro deletion?
Fluorescence in situ.
Yeah. Fluorescence in situ. Yeah.
Yeah, fish, the
Yeah.
fish technique, fluorescent in
Fish
situ
technique. Yeah.
hybridization. Yeah,
Yeah.
I will use the
Then what's
technique
the
to decrease.
translocation?
Yeah, to basically identify this thing, this microdeletion of the long arm of the chromosome number 7. Okay, so what are the findings you will get? As you can see in this patient, they will have very small chin. They will have very long philtrum. As you can see, this is a philtrum. This patient a very long philtrum. Okay, they will have very small nose and a very widened mouth. As you can see, their mouth is so widened. Okay, so small nose, widened mouth, a wide philtrum, a long philtrum, and a smaller chin. These are the characteristic feature of these patients. Apart from this, they will have the intellectual disability. Okay, and they are very extremely friendly. They have a very very highly developed verbal skills. As you can see, they will have very highly developed verbal skills, so they are very extremely friendly with the strangers also. Now, other than these findings, you can have a hypercalcemia, which is due to the increased vitamin D and calcium absorption. And because of this increased vitamin D and calcium absorption, what you will get is a constipation. So generally, these patients can also present you with the constipation because of this high calcium load inside their body. Okay, hypercalcemia can lead to the constipation. And if they ask you about this vitamin D status, so they will have very high vitamin D. And due to this vitamin D, they will have very high calcium. Okay. And one of the very important thing that they will have as a cardiovascular problem is the supravalvular stenosis. So it will present you as the aortic stenosis. You know the symptoms of the aortic stenosis, but here in this case, these are the supravalvular. This is not at the aortic valve, but above the aortic valve. You will get the stenosis of the artery. So the symptoms would be same as like the aortic stenosis, but it is happening above the aortic valve. Okay, the supravalvular aortic stenosis. And they will also get the renal artery stenosis. Okay, so the constriction of the aorta just above the aortic valve is the supravalvular aortic stenosis, which mimics the aortic stenosis normal wala. So everything is clear, you guys? Any
You
doubt?
just described the facial
Yes.
features, right?
Yeah, facial features.
Small nose, long philtrum. All these are together called as elfin faces.
Yeah,
Yes.
exactly. All of these together known as the elfin faces.
And because the patient is having renal artery stenosis, can this patient present with hypertension that we have been?
Yeah, absolutely. Absolutely. It can present with the hypertension or alkalosis because of the RAS activation, you know?
Okay. The coaptation of aorta, sorry if I'm not wrong.
Yeah.
The construction of aorta is occurring, like
Yeah,
super.
exactly. Above the
So
above the aortic valve. Yes.
above the aortic wall. Okay. Thank you.
Yeah. So it will mimic the aortic stenosis, but it is not an actual aortic stenosis, right? Okay, any doubt? Any doubt, guys? I'm moving forward now.
Okay.
Okay. So now the biochemistry nutrition, and we will study about vitamins here. We know there are two types of vitamin are in our body. Some of them are the fat soluble vitamins and some of them are the water soluble vitamins. You should know what vitamins are the fat soluble vitamins. These are vitamin A, D, E, K. You can remember this by ADAC. I used to call them ADAC, A, D, E, K. Okay. And their absorption is totally dependent upon the ileum and the pancreas, because pancreas has these enzymes which are required for the absorption of fat, and along with the fat these vitamins could be easily absorbed, right? And their absorption occur in the ileum. So whenever something happened to your ileum, whenever a disorder is affecting your ileum, what you will get a loss of fat, and along with the loss of fat you will get the loss of these vitamins. Okay, so every malabsorption syndrome that is causing a steatorrhea like your cystic fibrosis, I told you, you will get a pancreatic insufficiency in this scenario. The celiac disease, which affects your ileum also, or if you get a iliac bypass surgery somehow, then you will get a deficiency of these vitamins. Okay. Then the water soluble vitamins, which do not require any oily media to absorb, they will absorb just like that. Okay, the B1 is a thiamine, the B2 is a riboflavin, the B3 is a niacin, the B5 is a pantothenic acid, the B6 is a pyridoxine, the B7 is a biotin, B9 is a folate, B12 is a cyanocobalamin, and vitamin C is the ascorbic acid. All of them are the B, but one is a C, and A, D, E, K are the fat soluble. Okay, so in which scenario whenever you have a over toxicity of these vitamins, the three things you will get is a dermatitis, the glossitis, which is inflammation of your tongue, and the diarrhea. So diarrhea, glossitis, and dermatitis. These three things will happen in the deficiency, not in the toxicity, but in the deficiency. I'm sorry about that. So whenever you have a deficiency of these vitamins, the three things is common to every vitamin: diarrhea, glossitis, and dermatitis. Okay. And vitamin B12 is stored inside our body for like 3 to 4 years. So whenever the deficiency started occurring inside the body, it will take 3 to 4 years to develop the symptoms, because our body has a reserve for this much years. Okay. And similarly, the vitamin B9, if you stop taking the vitamin B9 right now, then the symptoms will appear after 3 to 4 months later. Okay. So whenever a question is some describe your case of megaloblastic anemia, and they will tell you some kind of any cause of it, and they will ask you the the time duration they will give you for like 6 7 months or maybe 1 year. So they will ask you that what is the cause of this megaloblastic anemia. You will answer the vitamin B9 deficiency, because vitamin B12 deficiency will take years to develop. Okay. And if they describe your scenario of patient having the deficiency for like 3 to 4 years or 6 years, then it could be a deficiency, it could be a megaloblastic anemia due to vitamin B12 deficiency. Okay. And you should also know that gastrectomy will always cause the vitamin B12 deficiency, because you require the gastric acid and their enzymes for the vitamin B12 absorption. Okay. And in any malabsorption syndrome, you will get the ADAC deficiency, the fat soluble vitamin deficiencies. And why I'm saying you this, because you will get the questions where the stem describe you either this malabsorption syndromes like celiac disease, pancreatic insufficiency, Whipple's disease, and other that tropical spur, then you will choose the option that is the ADAC deficiency. And if they describe your scenario for gastric bypass surgery, then you will first choose the vitamin B12 deficiency as the answer. Because you should know that vitamin B12 deficiency and vitamin E deficiency will have very similar symptoms. All the neurological symptoms or the RBC symptoms will be same in both these diseases. You will get the anemia and vitamin B12 deficiency. You will get the anemia and the vitamin E deficiency. You will get the neurological symptoms in the B12 deficiency, and same neurological symptoms are there in the E deficiency. But the patient history will help you determining the cause of these symptoms, right? If it is a case of gastrectomy, this must be the vitamin B12. If it is a case of malabsorption, this must be a case of vitamin E deficiency. You understand me, guys?
Yes.
Yeah.
Yes.
Yeah.
Please
Yes.
remember these facts. These are very important. Okay. Now the
Yeah.
vitamin A. You should know the
Um,
name of the vitamin A, which is
if
yeah.
I'm,
Someone is saying something.
yeah, I'm sorry to interrupt. Can we take a break of 5 minutes, or you can continue?
Yeah, sure. We can take a break of 5 minutes. We will meet at 9:20. Okay with you guys?
Okay.
Yeah.
Okay,
Okay.
then I think we will able to finish vitamin today, right?
Yeah.
Inshallah.
Exactly.
Yes.
Yeah. We can do it.
Okay. So 9:20 sharp.
Yeah.
Okay. So record. Okay, so vitamin A. What you need to know about vitamin A is where we use this vitamin first thing. Okay. What are the uses of vitamin A? What would happen if you become deficient of vitamin A? What would happen if you take too much vitamin? That is a toxicity. Okay. These three things you need to know about this vitamin A. So first of all, the name of vitamin, it includes a retinol, which is the aldehyde of vitamin A, the retinol, which is alcohol of the vitamin A, and the retinoic acid, which is the acid of the vitamin A. Retinol is found in our eyes, and retinoic acid is found in our epithelial cells. You need to know that vitamin A is required for all those special membranes or all those special cells inside our body which perform a special function like your skin, okay, and your eyes. They perform a special functions. So what happens if vitamin is not available to these type of cells? Then they will become very dysplastic. Okay, they'll become dysplastic. So basically, vitamin A is essential for the normal differentiation of the epithelial cells into specialized tissues like the pancreatic cells, the mucus secreting cells, your skin, your cornea. Okay. And when the deficiency of vitamin A happens, it will lead to the metaplasia of these cells. Okay. You need to know that vitamin A is used for the treatment of the APL, which is acute promyelocytic leukemia, because the receptors, the retinoic acid receptors, will become damaged in this leukemia. So you give the patient vitamin A for the differentiation of these cells. Okay, you will convert the leukemic cell into the neutrophils, and neutrophils have very short life, and that's why very easily you can get rid of this leukemia. So you use the vitamin A for the acute promyelocytic leukemia. Then you also use the vitamin A for the treatment of acne. You use the retinoic acids mostly for the treatment of acne. But before giving the patient this isotretinoin for the acne, you need to make sure the patient is not pregnant. So you will do first a pregnancy test. They will ask you what kind of tests are required before giving a patient vitamin A. This isotretinoin therapy. First of all is a pregnancy test. You need to make sure that the patient is not pregnant, and then you will give them at least 2 methods of contraception, and you will regularly check for them for their pregnancy, because they are highly teratogenic thing. This isotretinoin is highly teratogenic and and has very negative impacts on the baby. So that's why you need to make sure before prescribing these drugs. Okay. Then you also need to know that vitamin A is found in green leafy vegetables, in the liver. Okay. And the supplementation of vitamin A is given for the measles treatment. There are some patients, especially backward classes, which are already vitamin A deficient, and when they get measles, the measles virus will compete for the vitamin A stores in our body. So you need to give the vitamin A to the vitamin A deficient patient in the measles as a treatment to improve the outcomes. Okay. Otherwise they will the measles can also cause the death in the vitamin A deficient patient. You should know about that. Okay. And all trans-retinoic acid is used to treat the acute promyelocytic leukemia I already told you about, and the acne could be treated with the help of isotretinoins. Okay. I told you that it is required for the special function of all these cells: the pancreatic cells, the mucus secreting cells, the cells of your cornea, as you can see here, you know, just things. Now, what would
Can you
happen
please
if you,
repeat?
yeah,
Can you please repeat what was the role of vitamin A in measles?
yeah, actually, measles virus compete for the vitamin A stores in our body. Okay. And if we are already deficient of vitamin A, then what will happen? We will become very, very much more deficient, right? So you need the vitamin A as a treatment of the measles also to improve the outcomes of the disease. Otherwise, you will you will see in the microbiology section, the virology, that even the vitamin A the deficiency can lead to the death in the measles patient. Okay, so to prevent the death of the patient, you need to give him the vitamin A. Okay, you understand it now?
Yeah, I understand.
Okay, so leukemia, measles, acne, these are the 3 areas where you use the vitamin A as a drug or as a therapy. Okay, the vitamin is required for the normal differentiation. Now, what will happen if you become deficient of the vitamin A? First of all, how you can become the deficient of vitamin A? First of all, the first thing is you can decrease the intake of the vitamin A. Secondly, you can have these malabsorption syndromes. Whenever I describe you a history of a patient with pancreatic insufficiency or the chronic pancreatitis, the biliary obstruction, the malabsorptions like inflammatory bowel diseases, or any bariatric surgeries, any gastric bypass surgery, something like that. So they're gonna hint you for that deficiency of all these fat soluble vitamins, right? And one of them is a vitamin A. So the first presenting complaint is the nyctalopia, also known as a night blindness. The patient will have very impaired night visions. So they they will tell you that while driving, they just near miss an accident or something like that. They will give you a history of a patient where they will tell you that this patient might be having this night vision loss. It will describe your complete a patient in that. So night blindness is the first thing that you will see in the vitamin A deficiency. Secondly, I told you that it is required for the epithelial of skin, right? Skin epithelium. So after the vitamin A deficiency, you will get this dry, scaly skin, also known as a xerosis cutis. Okay, because vitamin is also required for the special function cells, right? Epithelial cells, which is into specialized functions. So after the deficiency of vitamin A, what you will get a corneal squamous metaplasia. Okay, and this corneal squamous metaplasia will present you as a white dot spot, as you can see here. This is a white dot spot, which is appears as a foamy appearance or the conjunctiva. And this is actually a keratin debris, you know, formed due to the metaplasia of the squamous cells in the cornea. Okay, you will get a corneal degeneration, which is known as a keratomalacia, and you will also get the immunosuppressions. Okay, so these are some symptoms which you will get due to the vitamin A deficiency. Whenever the question is time, describe your patient having a very low vision in the night and very dry scaly skin, you know, and some kind of a spot in the eye. They might not describe you a spot in the eye because it is very obvious, you know, and you can easily identify the disease if they tell you this. So they will describe you a patient with night vision loss and, you know, very dry scaly skin. So that's how you know this must be a case of vitamin A, just by these 2-3 things. Okay, you need to identify the disease. Then what will happen if you take too much of vitamin A? So this could be two types, you know, the acute toxicity and the chronic toxicity. You should know that vitamin A specifically, you know, hurts your liver. You know, it will destroy your liver. So that toxicity must involve the liver always, you know. So the acute toxicity will lead to the nausea, vomiting, the vertigo, and the blurring of the vision. And you can also get the headache. Remember this pseudotumor cerebri, you will study in the neurology section. And one of the cause of the pseudotumor cerebri is the intake of vitamin A, you know. So vitamin A can cause the headache due to the pseudotumor cerebri. You should know that also. Also known as the idiopathic intracranial hypertension. As you can see here, the idiopathic intracranial hypertension, it specifically occurs in the female only. Female like, you know, in the age of 30s or 40s. Okay, so nausea, vomiting, vertigo, and blurring of the vision. Whenever you get these symptoms, you will always think about the vitamin A toxicity. And then the chronic toxicity happens when you take too much of vitamin A for a very prolonged duration. You will get the alopecia, which is falling of the hairs. You will get the dry skin again. You will get the hepatotoxicity, which is very important, you know. Whenever you prescribe someone isotretinoin, you need to make sure their LFT count is normal. You need to check for the LFT also. And the enlargement of the liver is occur. You will get a hepatomegaly. You will get the joint pain. You will get the intracranial hypertension. As you can see, pseudotumor cerebri, you will get very headaches, you know, like migraine pain. You will also get the papilledema eventually. I will tell you this later in the neurology section, guys. Okay. So you should also know that vitamin A is very highly teratogenic and it is not an ideal supplement in the pregnancy. So they will describe you a patient who is pregnant and they will ask you what vitamin should be contraindicated in this patient, and it will tell the vitamin A. Okay. You should also know that the vitamin A actually interfere with the Hox gene pathway. Remember I told you about the Hox gene which codes for some transcription proteins which bind to the DNA, you know, at the enhancer sites, and it is responsible for all these hands, you know, fingers in your body. How much finger you are having in your hand, it is all dependent upon the Hox gene. Where your hand is right now, it is due to the Hox gene, you know. And if if you take this vitamin A, it will interfere with the Hox gene pathway. Okay. Any doubt, guys?
Good.
And you should know before prescribing a patient any isotretinoin, you need to make sure that it is negative pregnancy test, and you should always give them the 2 form of contraceptions. Okay, it can cause a cleft lip palate defect, cardiac abnormalities, therefore very contraindicated in the
I have a
pregnancy.
question.
Okay.
I have a
Yeah.
question. You have written something regarding brachial arch, and
Yeah.
would you like
Brachial
to?
arches, you will study that in the reproductive section. They are responsible for all these: your jaw, your neck, your thyroid bone, sorry, your hyoid bone, you know. So it will interfere with these pathways also, you know, your head and neck structures, and it will damage them. You will get the cleft lip and palate. That's why, because of this brachial arch abnormality, you can get the cleft lip and palate.
The derivatives of brachial arch are effective, and it does only affect the fetus, right? The adult will not be
Yeah.
affected with the effect on Hox gene.
Yeah. What? Please repeat it
The
again.
adult, the adult
Yeah.
male or
Adults are not
female
affected. Yeah. Adults are not
with
affected.
the
It's just the fetus.
the Hox gene effect will be seen only in fetus, right?
Yeah, because auxin is only active during the fetal life, right? I told you auxin is required for the proper, you know, identification of different parts. Your hand is there because of this Hawk's gene. Otherwise, it could be on your head, on over your eyes, or in your legs, right? It is a Hawk's gene to determine where your hand should be, where your finger should be, where your mouth should be. So you can see, you can imagine how much, how much teratogenic this isotretinoin is. It can do anything in your body, right? With the fetus.
Okay.
So now the vitamin B1, which is the thiamine, and the activated form of vitamin B1 is the thiamine pyrophosphate, TPP. And you need to know that it is a cofactor of different dehydrogenase reactions inside your body. And the four of them you should need to remember, which is a branch change keto acid dehydrogenase, the alpha ketoglutarate dehydrogenase, which is a part of your TCA cycle, the pyruvate dehydrogenase, which is in your glycolysis, and then the transketolase that you will study in the HMP shunt pathway, the pentose pathway, also known as, right? So these four examples you should remember. They will require the thiamine as their cofactor, vitamin B1. Dehydrogenase enzyme specially required it, right? And this is very important, the transketolase, because it is different. It is not a dehydrogenase enzyme, right? And it is present in every cell, especially in your RBCs, because your RBC is totally dependent upon this HMP shunt for the protection from the reactive oxygen species. You will study that later in the metabolism chapter. Just remember this for now, these four examples of the vitamin B1. Okay. So what happens if you become deficient with the vitamin B1? So you will get three things, either the Wernicke's encephalopathy, either the Korsakoff syndrome, or the combined Wernicke's-Korsakoff syndrome. What is in the Wernicke's encephalopathy? You will get a classical triad of confusions. You do not know your name. You do not know where you are right now. I mean, not you, but the patient. Okay. The patient will become very confused of his name, of his location, of the time. You will get the ophthalmoplegia, and especially the nystagmus will happen as in ophthalmoplegia in these patients. Rapid abnormal eye movements, you will see nystagmus. So they will describe you a patient who is having this nystagmus and very confusions, and he's having this ataxia. He will fall off very rapidly, you can see, because your this alcohol especially affects your cerebellum, and so does this vitamin B1. It is required by your cerebellum. So a deficiency of vitamin B1 which affects your cerebellum and can cause the ataxia. You should know that. And a classical scenario they will give you is a patient who is alcoholic, because generally alcohol will cause a deficiency of this vitamin B1, because in alcoholics, they just stop caring about their diets and just drink alcohol and do not care about their diet, and eventually they will become deficient of this vitamin B1. So we'll get a triad of ataxia, nystagmus, or the ophthalmoplegia, and the confusions. Second is the Korsakoff syndrome, which is an amnestic disorder. The patient will forget its details. First, the retrograde amnesia will occur, and then the anterograde amnesia will occur. Sorry, first the anterograde amnesia will occur, and eventually the retrograde amnesia will occur. What is the anterograde amnesia? That is the amnesia or the memory loss that occurs after the event. Okay, so he will not remember anything after drinking alcohol or having this deficiency of vitamin B1, and then eventually he will develop the retrograde amnesia. He will forget his name. He will forget about his family. He will forget everything. Okay, and that is an amnesic disorder. And you should need to know that this memory loss is always permanent. And patients sometimes try to confabulate to fill this memory gap. They will tell you that they meet a unicorn, and they take their memories and something like that. So they made the confabulations, to fill this memory loss gap. Okay, and the personality changes are always occur. As you can see, these patients are always alcoholic mostly. Okay, and in alcoholism you can expect a personality change also, right? And then comes your Wernicke's-Korsakoff syndrome, which combines all these symptoms. They will have this classical triad of confusion, ataxia, nystagmus, and then the memory loss. So this is a Wernicke's-Korsakoff syndrome, and the most important that you need to remember, it affects your mammillary bodies. Okay, they will ask you many times. I've encountered many questions on these mammillary bodies, so you should know that in Wernicke's-Korsakoff syndrome, you will damage your mammillary bodies. Okay, then comes the beriberi, and These are two types, the dry beriberi and the wet beriberi. In the dry beriberi, you need to know that it affects only your muscles and the nerves. Okay, so you will get a polyneuropathy, and it is a lower motor neuron, right? So you will get this hypotonia or the paralysis. Okay, you will get loss of pain and temperature sensations, and then you will get the muscle wasting. You will get the atrophy of your muscles. The weight loss will occur, and this must be a symmetric muscle wasting. You should know that. You will get the hyporeflexia or the areflexia, and that shows that it is a lower motor neuron disorder, not the upper motor neuron. You should know about this fact. They will try to confuse you with the vitamin B12 sometimes. There is a question where they have shown a patient with this neuropathy thing, and most of the people choose this vitamin B12 as an option, but it's actually the vitamin B1. They do not tell you anything about this Wernicke-Korsakoff syndrome, but they will just tell you that the patient is having a hyporeflexia, weakness, the muscle wasting, and some cardiac involvement, and that is a dilated cardiomyopathy you will expect in the vitamin B1 deficiency. Okay, the high output cardiac failure and the edema, of course, due to this heart failure, you will get the eventually edema. So whenever you describe a patient with having this hypotonia, paralysis, muscle wasting, edema, and the heart failure, you will always think about the vitamin B1. You guys understand what I'm trying to say here? Do not confuse this neuropathy with the vitamin B12 deficiency,
Yes.
because it is the upper motor neuron in the vitamin B12 and lower motor neuron in the vitamin B1. Okay. Then
Yes.
comes what will happen when a patient with a vitamin B1 deficiency comes to your office. So first thing that you will give that patient is not the glucose, but you should give them first the thiamine. Okay, if you give them the glucose first, then what happens that the remaining store of the thiamine will be depleted, and you will get the very precipitation of these symptoms. Okay, I forgot the word, sorry. The precipitation of these symptoms you will get. So make sure whenever you encounter a patient who is chronic alcoholic, and and in your emergency department, so you need to give them the thiamine first and then the glucose or the dextrose later. Otherwise you will get the precipitation of these symptoms. You will develop the confabulations, you will develop the memory loss, you will develop the ataxia otherwise. So impaired glucose breakdown will lead to the ATP depletions. High aerobic tissues like brain and heart, I told you already that brain and heart are highly aerobic tissues. Whenever there is a loss of oxygen or loss of ATP occurs, these tissue will be affected first, and that's why due to the involvement of the brain, you will get these neuropathy things. Okay. So in alcoholics or the chronic malnourished patients, you give the thiamine before the dextrose to decrease the risk of precipitation of the Wernicke-Korsakoff syndrome. And you should know that this I told you about this enzyme, this transketolase enzyme. You use this enzyme as the diagnosis of the vitamin B1 deficiency. So what happens is in your RBCs, there is an enzyme known as a transketolase enzyme, which is involved in the pentose phosphate pathway. So when you give the patient thiamine, the activity of this transketolase suddenly increases in the RBC, and that's how you know that patient is having a deficiency of this thiamine. So diagnosis is made by the increase in the RBC transketolase activity following by the vitamin B1 administration. Okay. Clear, guys? Should I move forward now?
Yes, you can move forward.
Okay. One more thing I want to tell you about is whenever you're having this, I forgot to tell you about this, that vitamin A controls the keratin production also. So it could also be used as a treatment of psoriasis. You should know that in the psoriasis, you will get very unregulated multiplication of these cells, of the skin cells, and there's inflammation is occurring inside the cell. Their maturation is less, and their division is more. So if you give the patient vitamin A, it will limit their division and it will increase their maturation. Okay, so vitamin A can also be used in the treatment of psoriasis. You should know that. And because vitamin A actually controls the keratinization, so in the deficiency of vitamin A, you can get the thick, dry, scaly skin. Okay. Like I mentioned it here, the thiamine deficiency could be caused the adult beriberi and the infantile beriberi. Infantile beriberi generally includes your heart, so we'll get the cardiomegaly. And the adult beriberi, it generally involves only your muscles normal. Okay, it is mostly a dry beriberi, but could be a wet beriberi if it involves your heart. You will get a different decreased reflexes bilaterally versus the vitamin B12 deficiency. You will get a hyperreflexia because of upper motor neuron involvement. But in vitamin B1, you will get a lower motor neuron involvement. So do not confuse. If you get neurological symptom in some kind of vitamin deficiency, it could be a vitamin B1, not the vitamin B12. Okay. Then comes the vitamin B2, which is, yeah.
Can you please repeat the last point?
Yeah, I told that whenever you got a question on the vitamin deficiency and they're telling you that it is a case of neuropathy, some kind of neuropathy. So mostly, most of us will think only about the vitamin B12 because we know that vitamin B12 causes the neuropathy, right? The neurological symptoms will be happen in vitamin B12 deficiency. But we forget to remember that vitamin B1 can also cause the neuropathy things. So how you can differentiate between the vitamin B1 and vitamin B12 neuropathy? That of I told you that in the vitamin B1 there is a lower motor neuron involvement, right? So you will get a decreased reflexes. But in the vitamin B12 deficiency, it is upper motor neuron involvement, so you will get a hyperreflexia. So do
Okay.
not rush for vitamin B12 deficiency. If you hear about this neurological symptoms, think about it whether it is a hyperreflexia or a hyporeflexia. Then choose your options. Okay.
And you just said that in infants the wet beriberi is more common, and in adults the adult, in adults
Yeah,
the
dry
dry
beriberi is, yeah. You can even get a question on UWorld on that thing. Okay. This is from UWorld actually. Okay.
Okay, sure.
Should I move forward now?
Yes.
Okay. So now the vitamin B12, which is also known as the riboflavin. Okay, your FAD and FMN are basically the flavins इनको हम कहते हैं. We call them the flavins. These are FAD and FMN, which are required for the succinate dehydrogenase complex that you will study about that in the TCS cycle later in the metabolism chapter. Okay, these FAD and FMN are required by the succinate dehydrogenase. And not just the T cell cycle, succinate dehydrogenase also takes a part in the electron transport system for the oxidative phosphorylation. You guys know about that. The complex 2 is a succinate dehydrogenase complex. Okay, and this complex requires the FAD. It carries 2 hydrogen with it. FAD actually, FAD and FMN carries 2 hydrogen with them. Okay, so vitamin B2 is required for their functioning, for the function of succinate dehydrogenase. Okay, and if a deficiency of vitamin B2 occur, it mostly affects your mouth area. You will get the cheilosis, which is the inflammation of the lips. You will get very dry, scaly lips. And there is a fissuring occurs at the at the corners of your mouth. You will also get the corneal vascularization. In this case, I really don't know what this term means, but you should remember that. I never encountered any question on this corneal vascularization, but you can just remember this as a buzzword. Okay, if the questions time might mention you this corneal vascularization, you should know about that instantly that this must be the case of vitamin B12. You should also know that the glutathione reductase activity assay is done for the identification of this vitamin B2 deficiency. What happens is basically on the addition of FAD, the glutathione reductase activity is increased. You will study about this glutathione reductase later in the chapter in the metabolism part. When I told you about this NADPH thing, what is the use of this NADPH, how it is used to fight the reactive oxygen species, you will study about this glutathione reductase enzyme there. Just know that glutathione reductase activity increased after addition of the vitamin B2 if the patient is having a deficiency. So that's how you know that the patient is having a vitamin B2 deficiency. Okay, just know about this glutathione reductase assay, know about this cheilosis thing, know about this FAD and FMN, and this succinate dehydrogenase most importantly. Then comes the vitamin B3, which is a niacin or also known as a nicotinic acid. Like vitamin B2, which carries the FAD and FMN components, the vitamin B3 constituents are NAD and NADP. NAD is used for the destruction reactions, and NADP is used for the making of some substances like cholesterols and steroids, fighting the reactive oxygen species, you require this NADP. Okay, and for the glycolysis, you require this NAD. For the TCA, you require this NAD. So vitamin B3 is a component of these things. Okay, it is derived for the tryptophan. Most important thing that you should know, that it is derived from the tryptophan. And also the vitamin B2 and B6 is required for the synthesis of vitamin B3. So in the scenario where you have this vitamin B2 or the vitamin B6 deficiency, you can also get the vitamin B3 deficiency. Okay, you should know vitamin D3 as a treatment of the dyslipidemias. You will study that later in the cardiology section about that, about this drug. The vitamin B3 is used for the treatment of dyslipidemia. It actually lowers our VLDL levels and raises the HDL levels. Okay, then comes the deficiency of vitamin B3. You should know again the glossitis, which is inflammation of your tongue. I already told you in the initiation of this vitamin chapter, whenever a deficiency of any B complex happened, the first thing you will encounter is a glossitis, dermatitis, and diarrhea, right? So similarly, in the vitamin B3 deficiency, you will get the glossitis, which is inflammation of your tongue. You will get a pellagra, which is consist of these symptoms like diarrhea, dermatitis, and dementia. Dementia is already you will know, which is loss of memory and strange behavior, or some other associated symptoms you will study in the neurological chapter, neurology. Study about this dementia, which is the memory loss along with associated neurological symptoms like change in behavior or something like that. You will get the diarrhea and you will get the dermatitis, which is inflammation of your skin. As you can see in the photograph, whenever you expose your skin in the sun, you will get this inflammation. You will get these blisters, ulcers over your skin, sun exposed areas. That's how there's a dermatitis. Okay, hyperpigmentation you will see. So whenever a question system describe a patient who is having a diarrhea, having inflammation in the skin, some ulcers or some blisters in the skin, and also having some kind of memory loss or a strange behavior or a change in behavior, you will instantly know that this is a vitamin B3, and this is known as a pellagra disease. Okay, now comes the Hartnup disease, which is also known as the neutral amino acid urea. What happens is the transporters that are present in your proximal convoluted tubule in the kidney, these transporters of these neutral amino acids like tryptophan are lost. You need to know that tryptophan is a neutral amino acid and the transporters are present in the PCT. But what happens is this Hartnup disease, that these transporters are lost. So that now the tryptophan is losing in your urine. And this thing is also known as a neutral amino acid urea. So whenever a question system describe scenario where the patient is having a neutral amino acid urea, some neutral amino acids are coming into the urine, you should know that this is a case of Hartnup disease. And I already told you that this tryptophan is required for the synthesis of vitamin B3, right? So what you will get in this Hartnup disease is the pellagra, which is a dementia, dermatitis, and diarrhea. Okay, so what is the treatment? You will give the patient very high protein diet that is rich in nicotinic acid and the tryptophan. Okay, now you should also know that when you give the patient vitamin B3 for the treatment of dyslipidemia, what you can expect is a facial flushing with the redness of your cheeks. Okay, and that itching redness of the cheeks you can expect, and that is not due to the release of histamine but due to the release of prostaglandins. Normally you see whenever you have itching or redness in your body due to some kind of a hypersensitive reaction, it is due to the histamine release, right? But here in this case, when you give a patient vitamin B3 and it develops this kind of facial flushing and itchingness, so you need to know that it is not due to the histamine release but due to the prostaglandin release. And that's why one of the treatment that you will give along with the vitamin B3 is the NSAIDs. You can give the patient aspirin or any other NSAID along with the vitamin B3 to control this facial flushing and itching. Okay, you can also get the hyperglycemia and hyperuricemia. And you should also need to know that in the carcinoid syndromes, because your serotonin is also derived from the tryptophan, in the carcinoid syndromes, all of the tryptophan is going to form the serotonin, so that you can again expect a deficiency of vitamin B3 in the carcinoid syndromes. I hope you understand it, guys. You will study the carcinoid
Yes.
syndrome later in the endocrine chapter.
Yes.
Okay.
Yes,
You will
yes.
study it
Yes.
later.
Do you have a
Yeah.
reason? Do you have a reason why there is increased prostaglandins in vitamin B3 deficiency?
No, there is no reason. I don't know about it, but yeah, it just happened. I've checked the you will have checked the emboss. Nowhere it is given. I didn't do Google yet. So if you find, please you can share with us. But you just need to know that prostaglandin is released after giving the patient vitamin B3. So you need to know you need to give the patient aspirin or other NSAIDs to control these symptoms. They will try to trick you that they will give you a scenario of a patient where he's receiving this vitamin B3 and suddenly he developed this facial flushing and itching in the body, and they will ask you what could be the treatment, or uh, they could ask you what is the reason behind it. So you need to choose the prostaglandins and the aspirin as a treatment. Okay, should I move forward now?
Yes.
Yes.
Okay, just remember this Hartnup disease, also as a neutral amino acid urea. Remember this carcinoid syndrome. Remember this tryptophan and vitamin B2, B6, and the prostaglandin thing. Okay, you're good to go. Then vitamin B5, which is also is a pantothenic acid, which is the coenzyme A in all these dehydrogenase reactions. The coenzyme A is actually the vitamin B5. Okay, and you will study later about this coenzyme A in the metabolism chapters. And the deficiency of vitamin B5 could lead to the alopecia, the dermatitis, the adrenal insufficiency. This vitamin is not very much important. I never encountered any question on it. So you can even leave it if you want, but just remember 2 or 3 facts about it in case if you encounter any question. Then comes the vitamin B6, another very important vitamin. I told you that vitamin B6 and vitamin B2 is required for the synthesis of vitamin B3, right? This vitamin B6 is known as the pyridoxine. It converted into the pyridoxyl phosphate PLP as their activated form. And you need to know that every transmitter synthesizing inside your body, it requires the vitamin B6 for its synthesis. Okay? All these ALT and AST reactions, all these ALT and AST is requires the vitamin B6. Okay, ALT AST found in your liver, as you should know. Okay, high ALT AST count. So this required the vitamin B6. Okay, and all these decarboxylation reactions you will study later in the metabolism chapter about these decarboxylation reactions. All of these reactions are required for the vitamin B6, and these reactions where your neurotransmitter synthesis actually occurs. And that's why I said every neurotransmitter requires this vitamin B6 for their synthesis. Okay, glutathione, cystathione, even the hemoglobin synthesis requires the vitamin B6. You will study that later in the hematology section. Okay, please remember this hemoglobin synthesis required the vitamin B6. Okay, every neurotransmitter like serotonin, epinephrine, non-epinephrine, GABA, dopamine, histamine, niacin, all of these things require the vitamin B6 for their synthesis. And should also need to know that vitamin B6 is very safe in pregnancy and could be used to control the nausea and vomiting in the pregnancy. Okay. And if the deficiency of vitamin B6 occur, which generally occur when you take the isoniazid, which is a drug used to treat the tuberculosis, it competes with the vitamin B6 store and lead to the excretion of vitamin B6 from our body, and that can lead to the deficiency of vitamin B6. Similarly, the oral contraceptives that female uses, it can also lead to the vitamin B6 deficiency. Please remember these two things, the isoniazid and the oral contraceptives. These can lead to the deficiency of vitamin B6. And what are the symptoms? You can get the peripheral neuropathy, you can cause the atopic dermatitis, glossitis, you can get the chlosis, you can also get the sideroblastic anemia. As I told you that vitamin B6 is required for the synthesis of heme. And you will study that later into the hematology section, how this deficiency of vitamin B6 going to lead the sideroblastic anemia. And one of the initial presenting complaint of the sideroblastic anemia or any kind of anemia is the fatigue. So whenever a patient come to your emergency department with some kind of a fatigue and some kind of a neurological symptoms, some glossitis, chlosis, you will instantly think about the vitamin B6. And of course, they will give you some kind of a history of tuberculosis or some kind of a female, they can ask you why this neuropathy is being occurring. Why? Because all these neurotransmitter requires the vitamin B6. And if there is no neurotransmitter, there is no transfer of the nerve impulses, you will get the peripheral neuropathy eventually. Okay. So is it clear, you guys? Clear to you guys? Okay. I move forward now.
Yes. Yes.
Any doubt you can ask me?
No, you can move forward.
Okay. So now comes the vitamin B7, which is the biotin, very good for your hairs. Okay, this vitamin B7. Remember I told you about vitamin B6 that it is required for the decarboxylation reactions. This vitamin B7 is required for the carboxylation reactions. Okay, to add a carbon to your substrates. For example, the pyruvate carboxylase, which converts our pyruvate into the oxaloacetate. It is required for the gluconeogenesis. I think it is the second step or the first step in the gluconeogenesis actually. This is a pyruvate carboxylase. It requires a vitamin B7 for their function. Then acetyl coenzyme A carboxylase, which converts the acetyl coenzyme A into the malonyl coenzyme A. You should remember this thing. Acetyl coenzyme A into the malonyl coenzyme A, and it is required for the fatty acid synthesis. You will study that later into the metabolism chapter. And then the propionyl coenzyme A carboxylase, which converts a propionyl coenzyme A into the methyl malonyl coenzyme A. It is a 4-carbon compound. This malonyl is a 3-carbon compound. So you can easily remember their name. It is malonyl, and because there is one extra carbon, it becomes a methyl malonyl. Okay, and it is required for the fatty acid oxidation. You will study that later into the metabolism chapter also. Okay, so please remember these 3 functions of the vitamin B7. And you should know that dermatitis, alopecia, because I told you initially that vitamin B7 is very good for your hairs. So the deficiency of vitamin B7 can lead to the alopecia. And you should know that if you ingest, excessive raw eggs, you can get a deficiency of vitamin B7. There's a very classical scenario, a very case they will show you where a patient just ingested lots and lots of raw eggs, and they will ask you what kind of vitamin deficiency could be there, and you will say the vitamin B7. Okay. Remember this fact that if you take too much of the raw eggs, you can get a vitamin B7 deficiency. Okay, any doubt in vitamin B7?
No.
Then comes a vitamin B9, which is also known as a folate. I told you in the second page, I think, when I was telling you about this pyrimidine thing, the synthesis of the pyrimidines. I told you that vitamin B9 and vitamin B12 are very important. And I will link these 2 vitamins from here. Okay, so you need to know that vitamin B9 is a folic acid. Okay, and it will convert to its activated form, which is a tetrahydrofolate. Okay, by the conversion from dihydrofolate to tetrahydrofolate by the enzyme dihydrofolate reductase, and that is the same enzyme which could inhibited by the methotrexate. Okay, and you need to know that vitamin B9 is required for the nitrogenous basis synthesis. I told you already that tetrahydrofolate converted into the methyl tetrahydrofolate N5 and 10 methylene tetrahydrofolate, and this methyl group will be donated to the DUMP so that it could be converted into the thymine, right? So vitamin B9 is required for the synthesis of pyrimidines for the thymine especially, okay, in the DNA and RNA. Now the deficiency of vitamin B9 could lead to the megaloblastic anemia because you're not getting any basis for the synthesis of DNA, right? So the maturation of RBCs would not take place, and ultimately you will get a very large size of RBC, greater than 110 micron, and this is the megaloblastic anemia. Okay, you will get a hyper-segmented polymorphonuclear cells because during the maturation process, all these multiple segments of the nucleus in the cells like neutrophils, it will reduces. Okay, but if you get a deficiency of folate, the maturation of cell is not occurring, and what you will get is hyper-segmented. Multiple lobes of the nucleus would be found greater than 5 lobes. Even 5, 6, 7 lobes of neutrophils would be seen in this vitamin B9 deficiency. Okay, you need to know that the deficiency of vitamin B12 will also lead to the megaloblastic anemia. So how will you differentiate between these 2 things? Well, the presence of neurological symptoms, because you need to know that in the deficiency of vitamin B12, I will tell you why. The neurological symptoms will occur due to the demyelination of the tracts, but not in the case of vitamin B9. So if you're getting a patient who is having some kind of anemia, and again, along with this neurological symptoms, you will think about the vitamin B12. But if you're having just a megaloblastic anemia, you will think about the vitamin B9. And of course, the Duration is very much important because vitamin B9 has a store of like 6-7 months. Okay, and vitamin B12 has a store of like 4 to 5 years. Okay, so think about it. And then where you can find the vitamin B9, it is found in all green leafy vegetables. So if if the question is describe you a case of a vegan who's totally dependent upon the leaves or the vegetables, they cannot have a deficiency of vitamin B9. They will surely going to have a deficiency of vitamin B12. That is the other way you can choose your options. And you need to know that vitamin B9 is absorbed in the jejunum. This is very important point because in the bypass surgeries, you can eventually get the vitamin B9 deficiency in the jejunum bypass surgery. So please underline this point. It is absorbed in the jejunum. Okay, so a small pool is always reserved inside our body for like 3 to 4 months, I told you. And it is very safe in the pregnancy. Whenever you give a patient any drug like methotrexate or any drug, it will require the vitamin B9 as a supplementation to prevent the toxicity. Also, in order to prevent the cases of spina bifida, you need to give the patient vitamin B9. It is so much important. Okay. Now, the labs that you should know that in case of deficiency of vitamin B9, you will get an increased level of homocysteine. You will get a normal methylmalonic acid levels. And you should know that in case of vitamin B12 deficiency, you will get a very high level of methylmalonic acid. So that is again a differentiating factors between this vitamin B12 and vitamin B9 deficiency. And that is the same methylmalonic acid, and due to which you're having these neurological symptoms in the vitamin B12 deficiency. It is due to this acid. Okay, and where can you get this vitamin B9 deficiency? Well, the pregnancy, because of increased demand in the pregnancy, you can get a vitamin B9 deficiency, and in the alcoholics because they forget to take any normal diet. They just focus on the alcohols, and so you can get a alcoholism. And plus, it's not just about the RBCs. Every cell inside your body requires a vitamin B9 for their maturation, for their development, right? So not just the RBCs, but the lymphocytes, but the neutrophils, but the megakaryocytes, the platelets, all of these cells are affected. And what you will get is a pancytopenia eventually. First is the anemia, then you will get the pancytopenia along with hypersegmented neutrophils. A very classical scenario for the vitamin B9 deficiency. Okay. So deficiency can also be caused by certain drugs like methotrexate, phenytoin, sulfonamides. So supplementation of folic acid is required for at least 1 month prior to the conception. Before the pregnancy, 1 month before the pregnancy, you should start taking the folic acid to prevent the neural tube defects like spina bifida. Okay, I told you about that. Okay, any doubt in vitamin B9 and its functions?
There is probably a pathway mentioned for methyl malonic acid. Why
Yeah,
it's
in the
increased?
next page. Yeah, in the next page, I will describe that pathway to you. Okay. Yeah.
Is okay.
Yeah. Okay. So now you should know about the vegan diet, because vegan diet is, completely dependent upon the plant products. You cannot consume any animal product, not even a cow milk. Okay. So in the absence of milk, what you will get a vitamin D deficiency and the calcium deficiency. Okay. And because vitamin B12 is rich in animal foods, not in the plant foods, so vitamin B12 deficiency is very common in these patients. So if a question stem asks you about a patient who is completely vegan, and then they will ask you that what kind of supplements you will give to that patient. So you will choose one of the three options, either the calcium, either the vitamin D, or the vitamin B12. Okay, and possibly they can also get a deficiency of iron, zinc, and iodine. Okay. And vegan diet is completely dependent upon the fruits, the vegetables, and the legumes, the dale. That is the only question they can made on the vegan diet. Just you need to know what kind of supplements are required to the patients who are dependent upon the vegan diet. Okay, the vitamin B12,
And,
vitamin D, and the
and
calcium. Yes.
here are written the benefits of vegan diet, like decrease
Yeah,
risk of
just
diabetes
this is
mellitus.
just the extra information if you want to write. They won't ask you question of it, but just the extra information if you want to write that it decreases the risk of diabetes mellitus and decreases the risk of myocardial infarction and the strokes. Okay, not significant, just for the knowledge purpose. Okay.
Okay. Okay.
Okay. Now you should know about this. Okay. The vitamin B12, very important. It is known as a cobalamin. Okay. And you should know that it is a cofactor of methionine synthetase, which transfers the methyl group as methylcobalamin. As you can see this here. Remember, I told you a pathway before for the pyrimidine synthesis. I told you sometimes this N5 N10 methylene tetrahydrofolate converted to the methyl tetrahydrofolate by the enzyme methylene tetrahydrofolate reductase, MTHFR. This converts the tetrahydrofolate into the methyl tetrahydrofolate. Now, this methyl tetrahydrofolate should need to be regenerated again. Okay, back to the tetrahydrofolate for the synthesis of DNA and RNA, right? So if there's a deficiency of vitamin B12 occur, then this whole tetrahydrofolate keep on converting into the methyl tetrahydrofolate, right? And eventually you will get a deficiency of this tetrahydrofolate. You won't get to synthesize the DNA and the RNA, and ultimately what you will get is the megaloblastic anemia. Okay. So megaloblastic anemia, it can be happen with the two deficiencies. One is the vitamin B9, because ultimately if you do not give the patient vitamin B9, they will have this deficiency of tetrahydrofolate. And similarly, if you do not give the patient vitamin B12, then this whole tetrahydrofolate is going to convert it back into the methyl tetrahydrofolate, and you will get the deficiency similar to B9, right? So tell me, guys, if a patient is having a megaloblastic anemia and I give that patient, and he's having the megaloblastic anemia due to the vitamin B12. If I give the patient folic acid, can I be able to correct the megaloblastic anemia in that patient?
No,
Why no?
because the patient is already having the folate and he's just not able to convert it into the tetrahydrofolate group.
No. That is not the case. I'm giving the patient vitamin B9. It is getting converted to tetrahydrofolate. He's having the tetrahydrofolate. But in the vitamin B12 deficiency, he is having too much methyl tetrahydrofolate, which cannot be converted into the tetrahydrofolate. But if I give a patient external tetrahydrofolate, then it is sufficient, right? And that could be done with the help of giving patient vitamin B9 supplements. Remember, I told you the activated form of the vitamin B9 is a methyl tetrahydrofolate. Sorry, the tetrahydrofolate, right? This is the activated form of vitamin B9. So if I give a patient, please mute your mic. I don't know who is this. There's too much background noise.
Please come on. Yeah.
Yeah, good now. So see, if there's a patient who is having a deficiency of vitamin B12, then he cannot convert his methyl tetrahydrofolate into the tetrahydrofolate. But if I give the patient external tetrahydrofolate, then I could be able to bypass this step, right? And what
Right.
happens now? He would be able to synthesize the DNA and the RNA now. So in a patient who is having megaloblastic anemia due to vitamin B12 deficiency, I could be able to correct the vitamin B12. Sorry, I could be able to correct the megaloblastic anemia, but not the neurological symptoms. Understand, guys, what I'm trying to say here?
Yes.
If you give a folic acid to a vitamin B12 deficient patient, you can easily correct the megaloblastic anemia, but you cannot correct the neurological symptoms. Okay. And
Okay.
similarly, tell me, guys, if a patient is having a vitamin B9 deficiency, so if I give the patient vitamin B12, can I able to correct the megaloblastic anemia?
No.
No, because there is no tetrahydrofolate in the first place, right? There is no tetrahydrofolate, so there is no methyl tetrahydrofolate, so there is no role of vitamin B12 left. Okay, there's a trick thing. Please remember this fact, very important. And this pathway could also be linked to that pyrimidine synthesis pathway. Very important. You need to be able to link that pathway. Okay. Now, the okay. So, where should you find this vitamin B12 in the food which is derived from the animal products? And that's why the vegan patient develops this vitamin B12 deficiency ultimately. Okay. And you need to know that there's a very large pool reserved in our liver for like 4 to 5 years. You can mention it here. 4 to 5 years of reserved storage there inside our body. Okay. Now, what can cause a deficiency of this vitamin B12? The first I told you is the gastric bypass surgery. Remember the gastrectomy, because I told you that stomach acid and these enzymes are required for the absorption of vitamin B12. The R binding thing, you will study that later in the GI section. the stomach is required, that intrinsic factors is found in the stomach. So if you do a gastric bypass surgery, you cannot get the vitamin B12 absorption. So this is the first thing that you should know. Gastric bypass surgeries can cause the vitamin B12 deficiency. Second is a parasite known as a Diphyllobostrium latum. It competes for the vitamin B12 stores. Now, if you have this parasite inside your body, even if you take the vitamin B12 supplements, you will eventually get the vitamin B12 deficiency, because it will just compete too much for the stores and eventually left us with the deficiency. So it doesn't matter if you take that supplements or not, you will get the deficiency in case of this parasite. Okay, the malabsorption syndromes that affects your ileum, specifically your topical sprue and the enteritis, you will get the deficiency of vitamin B12 because your ileum is required for the absorption of the vitamin B12. So anything which involves your ileum, you will get the vitamin B12 deficiency. The bacterial overgrowth, which is a syndrome known as subacute bacterial overgrowth syndrome, you will SIBO, you will study that later in the GI section. You will get the vitamin B12 deficiency in it. Alcohol excess, because I told you a patient taking alcohol will forget to take any diet other than the alcohol, so he will eventually get the deficiency of vitamin B12. Lack of intrinsic factor in case of this gastric bypass surgeries or gastritis, you will get this vitamin B12 deficiency. Surgical removal of the ileum, because I told you that ileum is required for the absorption of the vitamin B12, you will get the deficiency. And that could be happen in the Crohn's disease also, because you should know that Crohn's disease most commonly affects your ileum. Almost every time Crohn's disease affects your ileum, so you will get the deficiency of vitamin B12 in case of Crohn's disease. Certain drugs like metformin, which is a anti-diabetic drug, you will study that later in the endocrine section. Metformin can also lead to the deficiency of vitamin B12. And veganism is very important cause of the vitamin B12, and it will take like years to develop, right? So if
I
a
have a
question is
question.
yeah,
Why does the bacterial overgrowth leads to vitamin B12 deficiency?
uh, two, three reasons are there actually. First thing, you will have the diarrhea, so much diarrhea because of this overgrowth. So it would not be possible to absorb the vitamin B12. Secondly, they will feed on our stores of vitamin B12, remember? And that's why you can get a deficiency. Because of this diarrhea, most importantly, you were not able to, absorb anything because of this overgrowth of the bacteria. You will, get the inflammation in your GI tract because of this bacterial overgrowth. So in case of inflammation and case of diarrhea, you will lose your vitamin B12.
So first reason is that the vitamin will not be absorbed. Second is that because the vitamin is being used by the bacteria. That's what you said.
I'm not sure about the being used by the bacteria, but yeah, I'm sure that it is the diarrhea, and secondly, there is inflammation in your GI tract because of this bacterial overgrowth. And this bacterial overgrowth most importantly happen when you do a gastric bypass surgeries. So that is important thing that adds up to the vitamin B12 deficiencies, because generally SIBO occur in the patient who is having this gastric bypass surgeries.
Okay.
You will study that later in the GI section. I will tell you everything about this SIBO later. Okay.
Because the gastric acid is very important for the destruction of bacteria. So
Yeah,
in the
exactly. And when
okay,
you
I get
bypass the
it.
gastric acid, you will get this overgrowth of the bacteria. So two
This will
things are
ultimately
happening, and yeah.
and this will ultimately lead this bacterial overgrowth will ultimately lead to the inflammation of the intestine.
Yeah, exactly. You will see that the patient generally present you with the diarrhea and the abdominal pain, and he's having this inflammation inside the tracts. Of course, this inflammation gonna happen because of this overgrowth, right? Your immune system won't let the bacteria survive like that. So there must be an inflammation going on, right? And that's when the symptoms actually develops due to this inflammation. Okay. And generally, this SIBO always occur in a patient with bypass surgery. So this bypass also contribute to this deficiency of vitamin B12 itself.
Okay.
You will have a question on this SIBO. You will encounter that. You will see
Okay.
SIBO question. You will have it on. Okay. Now the other things, other functions of the vitamin B12. I told you that vitamin B12 takes up the methyl group and transfer it to the homocysteine, so that homocysteine could be converted into the methionine. And this methyl tetrahydrofolate can be easily converted into the tetrahydrofolate to be used by the DNA and the RNA synthesis. Okay. Now, what happens if the vitamin B12 and this methionine ultimately converted into the S-adenosyl methionine? Remember this SAM molecule I told you about? What function it do?
I don't know.
Yeah.
Use it as methyl donor methylation.
Yeah. It donates the methyl group. Remember the methyl transferase enzyme for the methylation process, the imprinting. Okay. This SAM enzyme is very much important for that. So now, if you get a vitamin B12 deficiency, then you are not able to convert your homocysteine back into the methionine. And you should know that this homocysteine is very toxic to your blood vessels, and you will get what a thrombotic attack, and eventually you will get the homocysteine urea. Remember the Marfan syndrome, homocysteine urea? Both of them have very similar symptoms, but you will get the intellectual disability in this homocysteine urea, and you will get multiple episodes of myocardial infarction in a very young age. So whenever you encounter any child or a very young patient having multiple episodes of myocardial infarction or the strokes, you will always think about this homocysteine urea. And vitamin B12 deficiency is a very important cause of this homocysteine urea. Okay. And another very important thing that I want to tell you about this methylmalonic acid, the fatty acids, most importantly, are branch change fatty acids and amino acids. They will convert it with the help of this, remember this enzyme, the vitamin B1
Branch and
branch chain,
fatty acids.
branch chain keto acid dehydrogenase. It will convert this keto acid, this amino acid, into the methylmalonic acid. So this step requires a vitamin B1. Now, after converting into the methylmalonyl coenzyme A, this methylmalonyl coenzyme A requires a vitamin B12. And this is a mutase enzyme that converts the methylmalonyl coenzyme A into the succinyl coenzyme A. And you should know that succinyl coenzyme A is a part of your TCA cycle. So by here, the these things can adds up into the TCA, can enter into TCA very easily. Or the succinyl coenzyme A along with vitamin B6 could be used for the synthesis of heme. So that's why this pathway is required. Now, what happens if you develop a deficiency of vitamin B12? You will get the very high level of methylmalonyl coenzyme A, right? And you should know that this methylmalonyl coenzyme A is very neurotoxic. It will cause the demyelination of your nerves in your tracts. And what you will get, a upper motor neuron neuropathy. You will get a demyelination of the tracts in your spinal cord or in your brain. Okay. And what you will get is a subacute combined degeneration of your dorsal columns. This is known as subacute combined degeneration that includes your dorsal columns. You will study them later in the neurological sections. The lateral corticospinal tract that leads to the weakness in your muscles. The spinocerebellar tract that lead to the ataxia. Dorsal column will lead to the loss of sensations. Okay. And likewise, I told you, you will get the megaloblastic anemia. And just like the vitamin B9 deficiency, you will get the pancytopenia because you're not getting the DNA and RNA for the cell maturation. So you will get the pancytopenia, you will get the paresthesias, you will get the subacute combined degeneration where you lost your anterior horns. Sorry, you will lose your corticospinal tract, you will lose your dorsal columns, and you will lose your spinocerebellar tract, not the anterior horns. And this is all the upper motor neuron neuropathy. Okay. Similar to this, you will also get the subacute combined degeneration in the vitamin E deficiency, and along with that, you will also get the anemia in the vitamin E deficiency. So you should know how to differentiate between these two deficiencies. And the important thing here is the history of the patient, whether he's having this malabsorption syndrome or
did
is
you just
yeah
sorry, did you just say vitamin E or vitamin A?
vitamin E for elephant.
Okay, and you just said this
Exactly.
in vitamin B12 there is upper motor neuron degeneration.
Yes, exactly. Upper motor neuron. These tracts, the corticospinal tract, the spinocerebellar tract, and the dorsal columns. These are all in the spinal cord, right?
Okay. Oh, yes, yes, yes.
So these are the upper
Yes.
motor neurons, right? Spinal tract, the corticospinal tract, are the upper motor neuron tract, right? So you will get the symptom regarding like the weakness, the ataxia, the loss of sensations, and of
And
course,
in
like I
vitamin B2, And in thiamine, we learned that it will be lower motor neuron because
Exactly. So yeah. So your voice is interrupted. Can you hear me?
I'm saying that in vitamin B2, we learned that it will be lower motor
B1.
neuron.
B1.
B1, yes, B1, thiamine. That hyporeflexia will occur in dry
Yeah,
beriberi
exactly. Yeah, exactly.
because of lower motor neuron degeneration.
And in this case, you will get the hyperreflexia. So do not confuse. They will tell you this about this tones of the muscle, whether he's having this increased reflexes or loss of reflexes. So please, look upon that. Okay, now, so I told you because this methylmalonic acid cannot be converted to succinyl coenzyme, you will get very high levels of methylmalonic acid. And because of this methylmalonic acid, you will having this subacute combined degeneration in this vitamin B12. It is very neurotoxic thing. Okay? And it will cause the irreversible nerve damage, you should know. The causes of damage the cause of deficiencies I told you here. And you should know that folate supplementation can mask the hematologic symptoms caused by the vitamin B12 deficiencies. I told you if you give the patient tetrahydrofolate, you can easily overcome the megaloblastic anemia, remember? But you cannot overcome the neurological symptoms. So it could be a scenario where the patient is having a megaloblastic anemia and you give the patient vitamin B9, but then again, after 2-3 months, the patient will, return to your clinic and he will tell you that he's having this loss of sensations and having this muscle weakness, and that's how you know that this patient is not having the vitamin B9 but a vitamin B12 deficiency. You will have similar questions like that. Okay, any doubt in it? This vitamin B12, you should know the function, you should know what causes the deficiencies, you should know what happened when you get the deficiency, you should know these two pathways, how it is linked to the synthesis of pyrimidines. Okay, should I move forward now?
Yes.
Yes.
Okay,
Yes,
then
you
comes
can.
the vitamin C, which is the ascorbic acid. You should know the function of vitamin C. It is an antioxidant. The vitamin A, vitamin C, and vitamin E, all of the three are the antioxidants you should know. Okay, vitamin C is very much required for the absorption of the iron because so vitamin C is also required for the synthesis, for the absorption of the iron, because it converts the iron into this Fe2 plus state from Fe3 plus, and this Fe2 plus state is better absorbable than the Fe3 plus state. Okay, so vitamin vitamin C for the antioxidant function and for the absorption of the iron. Now, you should know, I told you during the synthesis of the collagen for the hydroxylation step, you require this vitamin C, right? For the hydroxylase enzyme, proline hydroxylation and lysine hydroxylations, right? So it is required for the hydroxylation of lysine and the proline for the collagen synthesis. You will eventually learn in the later on chapter in the metabolism that vitamin C is also required for the synthesis of dopamine. I will tell you later in that chapter. Okay. Because of an enzyme known as a dopamine beta hydroxylase that converts a dopamine into the norepinephrine. It requires a vitamin C. Okay, so then there is a disease known as a there's a disease that is known as a methemoglobinemia, in which your iron converted into the Fe3 plus but cannot be converted back into the Fe2 plus due to deficiency of enzyme or some kind of a toxins. So you will give the patient vitamin C to convert this Fe3 plus into the Fe2 plus states. Okay, you should know this fact. You will encounter this later in the I think the kidney now in the respiratory the part. You will encounter this fact. I will tell you detail there in the respiratory tract. Just know this fact for now. Okay. Now the deficiency of vitamin C, I told you because it is involved in the collagen synthesis. So what you will get a easy bruising, delayed wound healing, swelling of the gums. You will get the hamartosis, which is basically bleeding into your joints. You can write it down. Hamartosis, which is basically bleeding into your joints. You will get the anemia because of the blood loss, right? And of course, because of this loss of iron in your body, you will get the anemia, iron deficiency anemia, as well as a blood loss. Poor wound healing you will get. Okay. And parafollicular and subperiosteal hemorrhages because of this, very weakening of the blood vessels. You will get the corkscrew hair, which is some kind of abnormal hairs you will find on your skin. They will show you a photograph. You will have a very nice photograph of this thing, the corkscrew hairs. And because of this hemorrhages, under your skin, you will get the hemorrhage. So you will get some kind of a rash, the petechial rash you will see on your skin if you get a deficiency of vitamin C. So petechial rash, the swollen gums, the easy bruising, hamartosis, which is bleeding into the joints, the anemia, the poor wound healing, the perifollicular or subperiosteal hemorrhages you will get, the corkscrew hairs you will get, and a very weakened immune response you will get. You see nowadays, due to the COVID, you are using too much vitamin C because, to boost up your immunity, right? So in case of vitamin C deficiency, you can get the very weakening immune response. Okay. So so the vitamin C deficient patient will also get the recurrent infection episodes. Okay. And of course, the bleeding time will, yeah.
I have a question. The perifollicular hemorrhage and subperiosteal hemorrhage. The
Okay.
perifollicular means the follicle
Around the hair
of the
follicles.
hair. Around the
Yeah,
follicle
hair
of the hair,
follicles.
their blood vessels get the blood vessels get ruptured,
Yes. And you will get the hemorrhage.
and
I know you can even
and
see this at a rash. Let me show you. Yeah, please continue.
below the periosteum, whatever the blood vessels are present, they will also get ruptured.
Rupture, yes. It's a periosteum layer. Periosteum is
And
the layer with that contains your germ cells. I told you, right?
yeah,
Okay, so
which
now,
contains the
please.
germ cells. Periosteum is the layer which
Sorry,
contains.
not the germ cells. I'm so sorry that these osteoblasts and osteoclast cells, stem cells, not the germ cells,
Yes.
stem cells.
And you just said that with vitamin C deficiency, you'll get increased bleeding time. So, what is the reason for that?
Because you are having delayed wound healing, right? You need the collagen to stop the bleeding. And if you do
Isn't the
not have
bleeding
any
time
collagen,
purely isn't the bleeding time purely related to platelets?
yeah, no doubt it related to the platelets, but here also you will get the increased bleeding time, but normal PT and PTT. This is a special case you should learn. Because it just not depend on the platelets, but also some kind, some extent to the collagen also. Okay.
Okay, fine.
Okay. So what I want to tell you about this, yeah, parafollicular hemorrhages. So you will get this kind of a rash all over your thighs. Let us suppose it's a thighs. You will get this kind of rash all over your skin, like that. So whenever you have this kind of a rash all over reddish rash over your thighs or over your arms or over your abdomen, you can think it about the vitamin deficiency, vitamin C, because of this parafollicular hemorrhages. It is a petechial type rash you will see. Okay. And again, these corkscrew hair, which are something like as this type of hair you will get. This is a corkscrew hair. You will have a nice photograph of this type of hairs. Okay, so you can refer to there. Okay, now the toxicity of vitamin C. What will happen if you take too much of the vitamin C? You should know that vitamin C will eventually convert it into the oxalate. And that's why if you take too much of the vitamin C, you will get the oxalate stones in your kidney. Okay, nephrolithiasis. It is a side effect of excessive vitamin C intake. You will get the nausea, vomiting, diarrhea, fatigue, and you should know if you're having an iron toxicity. Okay, for example, the hereditary hemochromatosis, or if you are a patient who is on the blood transplant, then you will eventually get the lots of iron stored inside your body. And above that, if you take a vitamin C, like I told you, that it helps in increasing the absorption of the iron, because Fe2 plus is very much easily absorbable than the Fe3 plus. So you should know that this in this scenario, in the hereditary hemochromatosis or very high iron state, the vitamin C is contraindicated. It will just worsen the symptoms. Okay. And a classical patient of this vitamin C deficiency would be an old age patient who just lost someone, or who is not taking care of someone, of himself, or he lives alone on a bread of pieces, on a pieces of bread, or some kind of these corns or something like that, or maybe alcoholic, or a severe malnourished patient. Generally these type of patient get this vitamin C deficiency. Whenever they want to give you a case of vitamin C deficiency, they need to tell you these things: either the malnourishment, either the alcohol, either the old age is must. No, old age. This is a very classical age group. they will get the vitamin deficiency. Okay, any doubt?
No, no, no.
Oh, just three more vitamins, and we will finish today. Okay, please bear with me, guys. Then comes the vitamin D, which is in the two form, exists in the two form, which is D2 and the D3 form. The D3 form is known as a cholecalciferol, and the D2 form is known as the ergocalciferol. You need to learn these names. Cholecalciferol you will get from the milk products, the fish, the plant products, and of course exposure to the sunlight by the skin. And the ergocalciferol you will get from the plant and the fungi products only. So whenever you heard about this animal products, you will think about cholecalciferol. Whenever you think about the plant products, you will think about this ergocalciferol. Skin, you will get this vitamin D3, cholecalciferol. Okay, now after and to require this cholesterol to be converted into the cholecalciferol, the cholesterol, when exposed to the UV rays, it will get converted into the vitamin D3 or the cholecalciferol. Now, after getting converted into cholecalciferol form, it goes to the liver, and there it meets an enzyme known as the 25-hydroxylase enzyme, and it will get converted into the 25-hydroxycholecalciferol. And then with the help of enzyme known as a 1-alpha-hydroxylase, it will get converted into the activated form, which is a 1,25-hydroxycholecalciferol into the PCT of the kidney. You should know the location of this enzyme, 1-alpha-hydroxylase. It is in the proximal convoluted tubule of the kidney. Okay. And it is, just this. Okay, so remember the storage form is in the liver. It is a 25-hydroxycholecalciferol, and the activated form is in the kidney, which is 1,25-dihydroxycholecalciferol. Okay. What is the function of vitamin D3? It helps in increasing the absorption of the calcium and the phosphate. Okay. It causes the bone mineralization at the low levels, but at the high levels, if you take too much of the vitamin D, it will start resorbing your bone. It will start destroying your bone. It will activate the osteoclast at very high level, at very high dose, and that's why you will get the bone destruction at high doses. But at the low doses, you will get the mineralization of the bone. Okay. And then there's this hormone which activates the 1-alpha-hydroxylase enzyme so that it could be convert the this 25-hydroxycholecalciferol into the activated form 1,25-hydroxycholecalciferol. This is a PTH hormone or the thyroid hormone that does that. Okay, so regulation की बात करते हैं. Let's talk about the regulation. If you have too much of PTH inside your body, let's suppose you get a deficiency of calcium inside your body. So what you will get an increased amount of PTH, because the sole role of this.
I'm really sorry to interrupt, but
Yeah.
you just mentioned that the enzyme 1-alpha-hydroxylase is present in proximal convoluted tubule.
Yes.
But you have another point you have written in about regarding distal convoluted tubule. Can you mention that again?
It is absorption of the phosphate. It is absorption of the phosphate.
It's written calcium
Absorption
binding.
Calcium. Cal binding is basically a protein which binds to the calcium and help in absorption of the calcium, and this happens in the DCT. Okay. Cal binding is a protein. Cal binding is a protein which is present in the DCT. Okay. What it does, it binds to the calcium and help in the absorption of the calcium in the DCT. Okay.
It's normally present in our body.
Yeah, exactly. It is normally present in our body and help in the calcium absorption.
In the distal convoluted tubule.
Yeah, exactly. Okay, so when you get a low amount of calcium in your body, you should know that the sole purpose of this parath hormone is to regulate the calcium inside your blood. Okay, so whenever you get a low calcium level, you will get a very high calcium. You will get this high level of this hormone. This hormone prevents the absorption of phosphate in your kidney. Okay, so you will get the low phosphate levels in your body, and you will get this, because of this increased hormone production, you will get the increased production of this activated vitamin D3. Okay, and you should know that both calcium as well as this activated vitamin D3 gives a negative feedback to this PTH. Okay, as well as to its own production. Vitamin D3 gives a negative feedback to its own production as well as gives a negative feedback to this PTH also. Okay, whenever you have an increased hormone concentration, you will get an increased reabsorption of the calcium and the loss of phosphate in the kidney. You should know the function of this hormone, okay? Then the deficiency of vitamin D, you will get the rickets in the children, which is basically a deformity of bone. Remember, I told you something about this hypophosphatemic rickets, which is an X-linked dominant disorder, occurs due to deficiency of phosphate in the body. You know, your bone requires both the calcium and the phosphate. Okay. So that is one thing. And the other thing in the rickets, it is due to the vitamin D deficiency, because vitamin D is required for the absorption of calcium. So with the vitamin D deficiency, you will get the loss of calcium, right? And so you will get the bone deformities such as genu varinum. This is the figure showing the genu varinum, which is bowing of the legs. Okay. You will get the osteomalacia, which is weakening of the bones in the adults. So it will describe them as a bone pain. You know, the question stem will describe you as a bone pain, this osteomalacia. Okay, the pain and weakness. And of course, you will get the hypocalcemic tetany. You should know that calcium actually, you know, closes your sodium channels. So in case if you lost the calcium, it will, you know, get too much activation of the sodium and eventually will get the tetany due to the hypocalcemia. Bone pain and abnormal bones. These are all the signs and symptoms of rickets. Okay, so what are the causes of rickets? It could be due to the malabsorption. I told you it is a fat soluble vitamin, and any scenario where you have this malabsorption of the fat, you will get the vitamin D deficiency. And the vitamin D deficiency, they will describe you a patient who is having, you know, something like inflammatory bowel disease, or might be a celiac spur, or might be a pancreatic deficiency, and then this patient started having this bone pain. So that's how you should know that this must be a case of vitamin D, because he's having a malabsorption syndrome and now he's having a bone pain. So this must be the vitamin D deficiency. Okay. So decrease in exposure can also lead to the vitamin D deficiency. I told you exposure to sunlight is very much required. So it could be a patient who is a nighttime driver, taxi driver, or a patient who who spend his time in the indoors only. They can also get this deficiency. The dark population can also very much likely to get the vitamin D deficiency, the Africans especially. Okay. The poor diet, of course, the chronic kidney disease, you should know that due to the CKD, you will get loss of calcium. Okay. And you will get and you will also get the inhibition of this 1-alpha hydroxylase enzyme in the kidney failure. And so that you will get the deficiency of, again, the calcium, and finally the rickets. Okay. Liver diseases can also lead to the vitamin D, because I told you liver contain an enzyme known as a 25 hydroxy 25 alpha hydroxylase, which converts the vitamin into its storage form. So if you get a liver disease, you will lose the storage of vitamin D. You will get a vitamin D deficiency. You should know that every breastfeeding infant should receive a vitamin D, because mother's milk is not very much rich in the vitamin D. And plus, if the baby belongs to African population, then it is very much required to give them the vitamin D supplements. Okay, please note that point. Vitamin D supplements to the infants.
Yes,
Okay.
another point that you have written regarding chronic kidney disease. Can you mention that due to increase in FGF2S? What does this stand for?
Yeah, you need to know due to okay, so you need to know whenever you are having a renal failure, you are having too much phosphate in your body, right? And one of the mechanism by which you can get rid of the phosphate is by activating the fibroblast growth factor 23. Now, this is a protective mechanism developed to control the phosphate stores in your body. What this growth factor does, it inhibits a 1-alpha hydroxylase enzyme, the same enzyme which was activating your vitamin D3. So once this enzyme get deactivated, you won't get vitamin D, and you should know that vitamin D actually help in the absorption of phosphate in your GIT, right? As you can see here, intestinal absorption of phosphate and calcium is done by the vitamin D. So right, this fibroblast growth factor inhibits the vitamin D so that your phosphate cannot be absorbed. But ultimately, what happens is you will lose the calcium also, right? And so that you will get the rickets ultimately. You understand it now?
So in hyperphosphatemia, that is an increased phosphate level, we can get this
That
mechanism.
generally happen in the kidney failure always.
In kidney
This is a
failure, the fibroblast growth factor 23 is increased, which
Yeah.
inhibits this 1-alpha hydroxylase.
Yeah, exactly. and that will lead to the inhibition of vitamin D, so that you cannot absorb the phosphate as well as the calcium. But what happens is you cannot lose the phosphate from the kidney. Okay,
Yeah.
you cannot lose the phosphate from the kidney, so that its store keep on increasing and increasing. But you will lose the calcium eventually because you're not having any vitamin D to absorb the calcium, right? So
Yes.
once this protective mechanism fails, you will started having this hyperphosphatemia and hypocalcemia. Okay, and the remaining phosphate, and this phosphate also combined with the calcium, so that the remaining free calcium can combine to the phosphate. You will get again more hypocalcemia, and one of the symptoms that you will get due to deficiency of this calcium and high phosphate is a renal osteodystrophy, which is a destruction of the bones happening in this case because of this high hormone level. Okay,
Peripheral hormone.
because somehow you need to make your calcium level normal inside your blood, right? So what this hormone does, it will act on the bone, it will destroy them, it will release the calcium from the bone, and ultimately you will get this renal osteodystrophy in the kidney failure patients. Okay.
Yes.
Okay,
Yes,
so Steph, I'm gonna ask you about this point. I got a question here from here on my step 1 exam. It was a baby who is having breastfeeding, and they will ask me. They asked me about this, that what supplement is required by this baby. So it would be a vitamin D. You need to know that breastfeeding infants should receive a vitamin D injection or a oral vitamin D, not injection, but oral vitamin D. Okay. Now, in case of excess vitamin D, you need to know that you will get, when you get too much of the vitamin D. I told you that it will start resolving your bone, right? As you can see here, and you will get a hypercalcemia as well as a hypercalciuria. You will lose too much calcium from your urine. You will get too much calcium in your blood, and hypercalcemia is one of the most common cause of constipation also, right? So you will get constipation, you will get loss of appetite, you will get this hypercalciuria. Okay, and how can you get this vitamin D excess or the toxicity? One of the thing is that granulomatous disease. Okay, for example, sarcoidosis. You need to know that in the granuloma, you have these macrophages, and these macrophages have this enzyme, this 1 alpha hydroxylase, right? Macrophages secrete this 1 alpha hydroxylase enzyme, and this will lead to the increased calcium absorption. Okay, so that you can get this hypercalcemia in case of any granulomatous disease. Because of this 1 alpha hydroxylase enzyme action, it will activate the vitamin D. It will get too much vitamin D, and you will get this hypercalcemia. Okay, similarly, the Hodgkin's lymphoma can also cause the excessive vitamin D. Yes, that's it. Any doubt in vitamin D? Guys, any doubt in vitamin D?
No, it's
Why
okay.
not?
No, sir.
No,
Okay, now
no.
then the
You just
vitamin E,
mentioned
which is,
you just
yeah,
mentioned Hodgkin's lymphoma, and the reason is same, or you have another reason for this?
uh, not the same reason actually, but a different one. I actually forgot the reason. I will mention it
What?
later in the hematology section for sure. Okay,
Okay.
just know for now that Hodgkin's lymphoma can also cause the vitamin D excess. It's somehow linked to the activation of vitamin D only, by the way. Okay, Hodgkin's lymphoma activates a vitamin D that causes the absorption of calcium too much. I will tell you later in the hematology section. Okay. Now comes the vitamin E, which is the tocopherol or the tocotrienol, which is the activated form of the vitamin E. You should know, like I told you, vitamin A, vitamin C, and vitamin E are the antioxidants. Okay, it protects the RBC from the damages. So you see now, if you have a deficiency of vitamin E, you cannot protect your RBCs from the oxidative damage, and as a result, you will get the anemia. Like I told you, in case of vitamin E, you can also get an anemia. Okay, it could be a hemolytic anemia, okay, which is due to destruction of the RBCs. Okay, and acantholysis you will get, acanthocytosis you will get, which is some kind of a hairy projections from your RBCs. You will study that later. Okay, the muscle weakness you will get, and the demyelination of the posterior column, which is similar to that of the subacute combined degeneration. Like I told you, the vitamin E and vitamin B12 have very similar symptoms. They both will get the anemia, both will get the subacute combined degeneration syndrome, the demyelination of the nerve tracts. So how could you differentiate between the two things? First of all, if they give you a megaloblastic anemia, then this must be the case of vitamin B12. If they do not give you a megaloblastic anemia, then they will surely give you some kind of history of gastric bypass surgery. And if you give you a gastric bypass surgery history, then this must be the case of vitamin B12 deficiency, not a vitamin E. And if they give you a malabsorptive syndrome like celiac spur or the Whipple's disease or the pancreatic insufficiency, then they must be giving you a case of vitamin E, not a vitamin B12. That's how you should differentiate between the two things, okay? As I mentioned here, the neurological presentation may be similar to the vitamin B12 deficiency, but without a megaloblastic anemia. Okay. Or you also won't get the methylmalonic acid level raised. You won't get the hyper segmented neutrophils. You won't get the pancytopenia, but you will get just the anemia in case of vitamin E deficiency. Okay. You should also know that if you give too much doses of vitamin E to a patient, it will, it will disturb the vitamin K functions. It will alter the metabolism of vitamin K, so that the anticoagulant effect of the warfarins are affected, because you know that warfarin is actually inhibits the vitamin K activation, right? So if you give a patient who is on warfarin, vitamin E, you should taper the dose of warfarin. Okay, otherwise you will get a toxicity of warfarin. Okay, any doubt in previous page? This is the last vitamin we will study, the vitamin K. Okay.
You just said that it is similar to Friedreich's ataxia. So how does it happen?
No, not the Friedreich's ataxia. Where?
You have written probably similar to Friedreich's ataxia.
Oh, symptoms. Yeah, yeah. You should know that vitamin B12, vitamin E, and Friedreich's ataxia have very similar symptoms. You know, both will, all of the three will get the demyelination of the posterior column. All of the three involve the, this corticospinal tract. All of the three involve the spinocerebellar tract. Okay, so symptoms are always similar for vitamin E deficiency, vitamin B12 deficiency, and Friedreich's ataxia also. You will study that ataxia later in the neurology section. You will see that vitamin B12 and Friedreich's ataxia have almost similar presentations. But some other involvements are also there in the Friedreich's ataxia, like, increase curvature of your foot and the involvement of your heart, hypertrophic cardiomyopathy and the diabetes mellitus. Okay. So the final, the vitamin K, you should know that vitamin K is required for the clottings. Your clotting factors 2, 7, 9, 10 are and the protein C and S dependent upon the vitamin K for their activations. Okay, vitamin K actually activated by the epoxide reductase, and that is the same enzyme which inhibited by the warfarin. Warfarin inhibits this epoxide reductase so that vitamin K can never be activated to activate these clotting factors. Okay. And you should know that vitamin K is required for the required as a cofactor for the gamma carboxylation of the glutamic acid. Okay. And of course, this vitamin K is not synthesized in your body, but it is synthesized by the intestinal flora, the bacteria. So in case of SIBO, the bacterial overgrowth, one deficiency you will not get is a vitamin K. Okay, you won't get a vitamin K deficiency in SIBO, but you can get the vitamin A deficiency, vitamin D deficiency, vitamin E deficiency, and vitamin B12 deficiency in case of SIBO. Okay. Then, as I told you, because vitamin K is involved in the activation of clotting factor 2, 7, 9, 10, and in the deficiency of vitamin K, you will get a deficiency of these clotting factors. So you will get the increased PT as well as the increased APTT. You will study that pathway later in the hematology section. That these all these things required involved in this. I'm sorry what I'm saying. Yeah, you will study that later in the hematology section. This whole pathway of this factors 2, 7, 9, and 10. Okay, but a normal bleeding time, you should know. If you get a vitamin C deficiency, you will get an increase in the bleeding time, but a normal PT and APTT. But in case of vitamin K, you will get an increased PT and APTT, but a normal bleeding time. Okay, and when can you expect a vitamin K deficiency? First of all, in the neonates, because neonates do not have any well-developed intestinal flora. So every neonate is required an injection of vitamin K. If you do not give the injection of vitamin K to these patients, you can expect a hemorrhage in the brain. Okay, bleeding in the brain of these neonates. So it is very much required by the neonates to use this vitamin K. Plus the patients on the antibacterial drugs, they disturb the intestinal flora, and you will get a vitamin K deficiency in these patients. So whenever you are using a drug like antibacterial drug, you should always taper the dose of warfarin in this scenario because it will cause a toxicity. Okay, and you should know that vitamin K is not in the breast milk, so you should give the patient vitamin K injection. Otherwise, you will get the hemorrhage in your brain, cerebral hemorrhage. Okay. And in the malabsorption disorders, you can also get the vitamin K deficiency because it is a fat, fatty vitamin. Okay.
You just mentioned in vitamin C. You just mentioned in vitamin C that it increases the bleeding time and PT and APT remains normal. And
Yeah.
now the finding in vitamin K are opposite of that.
Yeah, exactly. Ekdam opposite. Totally opposite, yes. So what are the symptoms of vitamin K? It will relate to the bleeding. Okay, you will get a deep bleedings like the hamartosis or bleeding in the joints. You will get the hematoma in parts of your body. You will get the easy bruising. So similar symptoms like that of the vitamin C deficiency, but bleeding time is normal and PT and APTT is increased. You will get very deep bleedings in case of vitamin K deficiency. Okay.
Yes, and you have mentioned red poison.
Red poison is actually the warfarin. Red poison
Acha.
contains a warfarin. Okay. So
Okay.
whenever a question is time mention you some kind of a suicide attempt where the patient ingested a rat poison, so they will ask you what is the antidote of this rat poison. So you should know the antidote of this warfarin. Okay, the fast frozen plasma, right?
Yes.
Okay, so we are done for today, guys. Any doubt in vitamin K, you can ask me.
That's okay. Got everything.
The previous slide where fibroblast growth factor 23 was mentioned, it is not
Yeah.
mentioned anywhere else in first aid, right? It was the point of U world or somewhere else.
You will see this fibroblast growth factor 23 in the renal section. I've copied it from there. Okay.
Renal
Yeah,
first
it's
And
aid.
a new word.
Yeah, and it is also in the UWorld. You will see a very deep explanation is given in the UWorld about this fibroblast growth factor 23. It is
Sure, it's
synthesized by
mentioned.
the osteoblast. Actually, you will see that it is synthesized by the osteoblast cells.
So the bone cell synthesizes and they inhibit the synthesis of
Yeah,
inhibit enzyme 1 alpha hydroxylase in the kidney.
yeah, exactly.
Okay. And it only happens in chronic renal failure, like renal failure things, not
Yeah,
normally.
only in the chronic lymph. It is a mechanism to control the phosphate stores. Okay, because in the renal failure you are having too much phosphate in your body. To control this phosphate stores, you need the fibroblast growth factor 23 to inhibit the vitamin D. Okay, a mechanism is developed in your body already.
Okay. And the last point regarding cholestyramine you have mentioned in vitamin K only. So
What point?
the cholestyramine, the which inhibit the bile acid absorption. So you have just mentioned regarding vitamin K or
Yeah. Vitamin A, D, E, K, all are affected.
because the bile acid is important for the absorption of all fat soluble
Yeah,
vitamins.
yeah, exactly.
Okay. Thank you.
Okay, should we wind up now, guys?
Yes.
Yes,
I
thank
think
you.
Okay,
yeah.
thank you so much. It was a long lecture today. It's almost 11.
Yeah.
Thank you for your time.
Okay. Okay, thank you
Yeah.
so much,
Thank you
guys,
so
for joining me.
much.
Thank you.
Thank you,
And
sir.
Thank you so
Thank
tomorrow
much.
we
you
will be
very
doing
much.
the metabolism, right? Tomorrow we will be finishing
Yeah,
up, right? The
yeah. We will
metabolism.
finish the metabolism tomorrow. Yes.
Yeah.
So will you
Okay.
be
Thank
doing
you. Thanks a
according
lot.
to first aid or it's just the biochemistry you're touching and then you will move on to systems?
First we'll finish up. Nee. We will move according to the first aid only. The
Oh,
biochemistry, then the immunology, then the microbiology, and then the
yes.
PAT and all these things. Okay.
Okay,
Yeah.
sure. Thank you.
Tomorrow at the same time?
Yeah, same time, 4:30.
Okay, thank you.
Okay. Thank you so much, guys.
Thank you.
Thank you,
Thank
sir.
you. Thank you.
Have a nice
I got to send us the recording.
Good night to India and good morning to the USA.
Good night.
Yeah.
Thank you.
Yeah, thank you, doctor.
Thank you so much.
Sir, one more thing. Tomorrow can we end up early because this is too late.
Tomorrow can we?
End up early.
We will try our best, but we need to finish some metabolism tomorrow, right?
Yeah, we will finish metabolism, but like around 10 o'clock, like
Yeah,
yesterday.
sure, yeah, definitely. I want the same actually.
Because this is too late. So that
Yeah,
I
I know it is too late. Yeah, I know. I can understand that. We'll try to speed up tomorrow for sure. Okay, we'll speed up from the tomorrow.
Okay, thank
Try
you,
to
sir.
early. Okay, thank you. Thank you so much.
Excuse me, are you able to send us the recording lecture?
Oh, sorry. Let me stop the recording.